Welcome to BFR Radio, a podcast dedicated to all things blood flow restriction training. This podcast is proudly sponsored by the BFR.co, where if you want to buy your own BFR cuffs, access online BFR training programs, increase your own BFR knowledge, or you want more information about this type of training, this is your one place to go. And I'm your host, Dr. Chris Gavilio. Welcome back to this episode. It's great to have you here. In this series, we're looking at how we can use BFR to assist with injuries. This is relevant with the end of season surgeries, and in particular here in Australia after the football season. And with all the evidence that supports the use of BFR in these scenarios, if you aren't using it, I feel you're missing out. However, for those who include BFR as part of your rehab program, I'm sure you've all found that some aspect of your rehab was just better than traditional non-BFR rehab programs. In our previous episode, which was the first episode in the series, we kicked it off by looking at how to use BFR to improve outcomes of ACL reconstructions. This is quite a big area, so part one focused on how you can incorporate BFR pre-surgery and how to use it in the acute post-operative stage, looking at passive strategies to mitigate any muscle loss due to not being able to use it as much. Going into an operation, being as strong as possible improves outcomes post-surgery, and preventing as much muscle loss, or rather muscle atrophy, is very important for long-term success. Muscle atrophy and strength loss are major consequences of ACL injury. In particular, a most frequent finding is weakness of the quadriceps muscle group, in particular the vastus lateralis and medialis muscles. The vastus lateralis being lateral, is the muscle which sits on the outside of the quad, and the medialis, medial or middle, sits on the inside. This is the quad muscle that gives that teardrop look, perhaps the most noticeable quadricep muscle. This episode is part two, and hence we'll focus on how to use BFR with low load resistance exercise, the point of where we can start doing some form of strength exercises. To do this, I'm going to access a few different articles. The first two actually come from systematic reviews. That's where we put all these really great studies together. And then I'm going to dig into a couple of them to give you a little bit more detail. And one of them in particular is by a group of Australian researchers and doctors, and this is called Blood Flow Restriction Training in Rehabilitation Following Anterior Cruciate Ligament Reconstructive Surgery, a review. And there's another one which has some really good tables in it, which outlines some protocols, which if you're really interested, I always urge listeners to get the article and dig into a little bit further. And that one is called Pre-operative Blood Flow Restriction Rehabilitation in Patients Undergoing ACL Reconstruction. To help understand the importance of a quality rehab program, and when we look at lower limb muscle volume before and after ACL reconstruction surgery, it's been reported that there is up to 15% atrophy in the vastus lateralis and rectus femoris compared with other unaffected limb. And when we look at the quadriceps muscles post-surgery, there's up to an excess of 20% in a symmetry of these muscles. These changes due to the atrophy affect consequent muscle activation and strength, and explains a large portion of the weakness of thigh muscles in that first 12 weeks post-surgery. Quadriceps strength deficit can exceed a 20% loss of normal muscle strength 6 months after ACL reconstruction, and such weakness can remain for over 2 years post-operation. Hence, it's really important to get this right at the beginning. The loss of strength because of muscle atrophy and decreased muscle activation is pretty much unavoidable because of the necessary restrictions placed upon the post-injury and post-surgery recovery process, such as reduced load and weight bearing to ensure that the graft is not overstrained in those early stages of recovery. However, muscle atrophy and impaired voluntary force control negatively impacts knee function following ACL surgery. In addition, there's also permanent anatomical changes associated with ACL reconstruction. These aspects all impact upon the nation's physical function, quality of life, and the recovery process. And as we established in part 1, the use of heavier loads are contraindicated in the rehabilitation phase. This, I'm sure, is pretty obvious to all of us. And one of the things that we really need to consider, in particular with the ACL, is around graft failure, because we don't want to put excess strain on the new graft. And this is where BFR is an invaluable tool to help increase muscle strength and size without placing unwanted strain loads on the graft and the knee joint. Phase 1 of the ACL rehab program, we've already covered. This is where we used passive BFR to help prevent muscle loss. For example, using a protocol of 5 sets of 5 minutes of inflation, followed by 3 minutes of rest, or rather deflation, can help attenuate or decrease muscle mass and strength of the quadriceps muscles. And also the addition of using neuromuscular electrical stimulation provides a potentially greater effect than either BFR or NEMS alone. And this is where we pick up how to use BFR for this episode, Phase 2. And if we refer to another fantastic resource, this is called the Melbourne ACL Rehabilitation Guide. And these are by Australian authors Cooper and Hughes. This is a free downloadable PDF, and anyone can access it to look at the different phases that are involved in an ACL reconstruction. And if we look specifically at Phase 2, the primary goals of this is to regain muscle strength, balance, and basic coordination. This phase usually commences with easy bodyweight type exercises and progresses into a gym-based regime with a mixture of resistance, balance, and coordination exercises. It's important to listen to the knee during this phase and only progress as the knee allows. The 3 most important goals of Phase 2 are: 1, regain most of your single leg balance; 2, regain most of your muscle strength; and 3, single leg squat with good technique and alignment. Now, this is a general ACL rehabilitation guide. I know some people in the sports world would try and push and accelerate this. However, we need to make sure, irrespective of whether you're general population or you're an elite athlete, that we get the foundations and we get the basics right. And that's what I'm going to be covering here, is we're going to get the foundations set up correctly in this Phase 2. Before we look at a few BFR specific studies, I actually want to highlight some of the outcome measures and goals that are related to this phase that are in this document, because I think it really helps to give a little bit more context about what we should be trying to achieve. The first is to establish good range of movement in the knee and get it closer to the non-injured knee. Then it's important to be able to understand where the body needs to be with respect to muscle strength and movement quality. And this would include exercises such as performing a single leg bridge, calf raises, single leg squat, a single leg sit to stand, side bridge endurance, and single leg balance tests. For example, the single leg bridge and calf raises, the goal is to be able to perform greater than 20 repetitions on the ACL affected side and to be at a standard that is at a minimum of 80% compared with the other side. Supplementary measures and goals are also suggested, such as being able to perform a 1RM single leg press and squat or trap bar to a knee angle of 90 degrees at 1.5 times body weight. But as with all good rehab programs, we need to start simple with our exercise prescription and slowly progress the exercises to gym-based, where we are looking to performing loaded single and double leg strength exercises. This podcast isn't going to go through that, but rather highlight some studies, how effective adding BFR is compared to when we don't use BFR. And our first study is by Otter and colleagues and is called Low Load Resistance Muscular Training with Moderate Restriction of Blood Flow After Anterior Cruciate Ligament Reconstruction. I just got to say, all these articles are a mouthful. Anyway, what I like about this study, it's a 16-week study. It's a little bit longer term because most of the time the studies that we read out there are 3 to 4 weeks. And really what they're looking at is what's the difference when you add BFR to low load strength training. And to do this, they had 44 participants and they had an even split in the BFR and the non-BFR group. Both groups performed the same exercise program, except the BFR group used an inflatable cuff at a pressure of around 180 millimeters of mercury. Although they use an absolute pressure here, by the looks of it, it's really important to note that you should be looking at individualizing your pressures according to your cuff width and also your limb circumference. Back to the study, and during the first week, both groups did the exercise program without BFR. From week 2, the BFR group started to use the cuffs. If we look at this, it's actually a progressive program. It's performed 6 days a week. And if we look at the first 8 weeks, the first group of exercises was a straight leg raise and a hip abduction. That's where the hip or the leg is going away from the body. And they did 2 sets of 20 repetitions. The hip abduction at weeks 2 to 4 after surgery. A 1 kilo weight was attached to the foot. And at weeks 5 to 8 after surgery, this was increased to 2 kilograms. The next exercise they added into this program was hip adduction. That's when the leg is coming towards the body. And they performed this by squeezing a ball between both knees for 5 seconds. Again, they did 2 sets of 20 repetitions for the first 12 weeks. So remembering those first 2 exercises was from weeks 1 to 8. And this third exercise was for a whole 12 weeks. Then at week number 5, a half squat exercise was introduced. 2 sets of 20 repetitions, holding for 6 seconds at the bottom of the exercise. And in this, the load was increased every 2 weeks by holding a small dumbbell in each hand. This exercise was included up to week 16. Once again, a really nice graduation of exercises where the first few weeks really simple, and then those first 2 simple exercises get slowly progressed out, and something like a half squat gets introduced from week 5. Then at week 9, a hamstring exercise is introduced with a specific limited range of movement. And in week 13, a knee bending walking exercise was introduced. It sounds like when you read the methods, this is where the participants walked in a half squatting position for 60 steps for 3 sets. I'd imagine it would be quite demanding on the quads. And as we see that they introduced this at week 13, we would assume at this stage is they've got a bit of strength in those quads. Overall, a progressive rehab program, and probably of all the articles that I read, one of the best ones out there in terms of it was 16 weeks and it involved a progression of exercises in terms of complexity and more than one exercise as well. When we look at the results, the pattern is remarkably consistent. Incorporating low load resistance training with BFR during the first 16 weeks after ACL reconstruction produced substantially greater improvements in strength and muscle size than performing the same rehab program without BFR. To assess strength, the researchers used what they call an isokinetic dynamometer, and they did this at 2 testing speeds, the first at 60 degrees per second and the second at 180 degrees per second. These speeds are pretty standard in rehab research, and the 60 degrees per second is a slower speed and it places greater mechanical demand on the muscles and is commonly used as a proxy for assessing maximal strength. In contrast, the 180 degrees per second is a much faster contraction. Think about it like a leg extension and a leg curl. You're able to do this at much faster speeds, and this, as we would guess, it would be able to capture the muscle's ability to produce force at speed, and often reflects a more functional performance as we start to progress to sporting tasks. For the quads, at 16 weeks post-surgery, concentric knee extension strength at the slower 60 degrees per second recovered to only 55% of the healthy limb in the non-BFR group, whereas the BFR group reached 76%. That's a 21% advantage for the BFR group. A similar pattern emerged at 180 degrees per second, with the non-BFR group recovering to 65% and the BFR group to 77%. Then they performed an isometric strength test set at a specific angle of 60 degrees, and the BFR group demonstrated a 21% difference, recovering to 84% compared to just 63% in the traditional non-BFR rehab group. These differences clearly show that BFR can accelerate quadriceps strength recovery during that early post-operative period. The hamstrings also benefit, though the effect size was more modest. And this, in my opinion, was more due to the program design with a greater focus on quad dominant exercises, with really the only exercise that trained the hamstring a lying leg curl within a specific angle using band resistance. This just wasn't enough work there. If we look at muscle size data, and this provide even more compelling evidence for the BFR group, quadriceps cross-sectional areas declined by 8% in the non-BFR group, whereas the BFR group actually increased muscle size by about 1%. In other words, BFR not only prevented post-operative atrophy, it produced slight hypertrophy during a period where muscle loss is typically expected. They also took muscle biopsies to understand what was happening to the muscle fibers. Although the sample size was smaller in this group, they only had 8 participants per group. Single fiber analysis revealed that our slow twitch, our type 1 fibers in the non-BFR group, decreased to 95% of their pre-operative size, whereas those in the BFR group increased to 103%. Type 2 fibers, our fast twitch fibers, really important for the athletes out there, the non-BFR group decreased to 97%, while the BFR increased to 102%. Taken together, these results demonstrate that adding low-load BFR to early ACL reconstruction rehab enhances both strength recovery and muscle preservation far more than identical training performed without BFR. Even with relatively simple exercises and low external loads, patients undertaking BFR achieved faster and more complete restoration of quadriceps and hamstring function, maintained muscle size, and minimized fiber level atrophy, all within that critical first 4 months after surgery. There's a few other studies I'd like to just briefly outline in this next study, which was titled Comparing the Effectiveness of Blood Flow Restriction and Traditional Heavy Load Resistance Training in the Post-Surgery Rehabilitation of Anterior Cruciate Ligament Reconstruction Patients. Once again, another mouthful. In this, they compared low-load BFR training with traditional heavy load strength training during early ACL reconstruction rehab. Both groups followed the same unilateral leg press program twice a week for 8 weeks. Once patients met certain criteria, such as pain-free weight bearing and being able to flex their knees to 90 degrees, and the ability to perform straight leg raises without quadriceps lag. In other words, that they had to have had some level of rehab or some level of progression after their program. Because as we said earlier, we can't just throw them into heavy load resistance training, because in this group, they train at 70% of their 1RM, performing 3 sets at 10. Whereas the low load BFR group trained at 30% of their 1RM using the classic 75 rep protocol. That's 30 reps followed by 3 sets of 15, where the BFR pressure was set at 80% of limb occlusion pressure. Now, just briefly here, we see in that first study that I unpacked is the program was a lot more complex and probably a bit more reflective of what we would expect from a rehab program, where in this one here, this is one exercise only. So it's a little bit more limited in terms of a rehab program that we would follow, but it's the overall concept that we want to really take away from the study's results. And when we do look towards the results, both training programs produce large improvements in leg press, 10 repetition maximum strength test. In the injured limb, the blood flow restriction group improved by 104%, while the heavy load group improved by 106%. And typically when we do compare low load BFR studies to high load non-BFR studies, is that high load training still produces really great results if the participants are able to perform high load. But what's really cool here is that because we normally need a minimum of 65 to 70% of 1RM to get any kind of strength improvements, to be able to do this at such a low load of 30% of 1RM is pretty amazing. In this study, they also used ultrasound to assess muscle thickness. and showed an increase of around 6% in both conditions, which demonstrates once again that low load BFR can stimulate muscle growth comparable to heavy resistance training. Where things became more interesting in this study is how the patients felt and functioned. Across all patient-reported outcome measures, improvements were consistently larger or better in the BFR group. Now, this was across a whole heap of different measures, but just really briefly, some of the measures included functional abilities such as a single leg balance and a dynamic reach. This improved more in the BFR group, suggesting a quicker return of coordinated movements. And pain and swelling showed some of the most meaningful differences. There's a thing called a KOOS pain score, KOOS pain score, and this improved by 67% in the BFR group versus 39% in the heavy load group. And near fusion, or the amount of swelling or fluid in the joint, decreased by more than double in those using BFR, indicating better joint comfort and recovery. Range of motion also followed this pattern, with knee flexion deficit improving by 80% in the BFR group compared to 42% in the heavy load group. Importantly, despite these positive outcomes, neither approach jeopardized graft safety, as both groups demonstrated similar reductions in knee laxity and no adverse events were reported. Overall, this study showed that low load BFR is at least as effective as heavy load for regaining strength, while offering additional benefits in pain reduction, swelling management, and patient-perceived functional recovery during the early phases in this rehab program. Another BFR adjunct to add to the rehabilitation program that I haven't discussed is low-intensity walking and cycling. In non-ACL studies, there's evidence for both modalities to improve muscle size and strength, alongside improvements in aerobic fitness, more so in general population than elite athletes. From what I've been able to find, there aren't any studies that look at the effects of BFR cycling or walking performed in this first phase 2, in this acute phase of an ACL rehab program. And to be honest, if you're looking at what will give you the best outcome, a strength-based training program will be your primary focus. Therefore, I probably wouldn't actually specifically go out and try to do just walking or cycling only, but rather an adjunct of that with strength training. However, I have found one cycling and one walking study that looked at individuals who had ACL reconstructions, but when they started this intervention, it was some period of time after that initial acute phase. To give you an idea, I'm going to focus on the walking study, and the inclusion criteria was that they have had to have undergone an ACL reconstruction at least 6 months prior and presented with a greater than 10% strength deficit in knee extensor muscles of the operated limb. For this study, the participants completed a 12-week progressive walking program, with durations progressing from 12 to 20 minutes and walking speeds from 1.25 to 2 meters per second, 3 times a week over the 12 weeks. They wore an 18 centimeter wide BFR cuff and inflated it to a pressure of 90% of arterial occlusion pressure, quite a high pressure. And they wore it on the ACL leg only. And on their uninjured leg, they had no cuff. And this served as the comparison or the control. Looking at the results, the most notable findings were in muscle strength, particularly in the weaker limb, which is clinically relevant in post-ACL reconstruction populations. If we look at the ankle plantar flexors, the weaker limb increased strength by 51.6%, whereas the control limb improved only 11.7%. Also, dorsiflexor strength, that's in the foot, these changes were smaller, non-significant, but the pattern again showed a slight increase in the weaker limb, that's an additional 5.9%, compared to a smaller decrease in the control limb. So this confirmed that the weaker limb benefited substantially more from the walking BFR intervention. In terms of knee function, knee extensor strength, we think about a leg extension, how strong we are in that leg extension movement. In the weaker limb, it improved 33%, while the control limb increased only 14.2%. 8.9%. Knee flexor strength, think hamstring curl, followed the same pattern, increasing by 25.7% in the weaker limb compared to 8.9% in the control limb. Before the intervention, the weaker limb exhibited a 26% deficit in knee extensor strength compared to the control side, and after 12 weeks of BFR walking, this asymmetry had reduced to just 3%. This effectively restored symmetry from the ACL side to the uninjured, non-affected limb. Interestingly, no meaningful hypertrophy was detected in the quadriceps muscles, in the quad and hamstring muscle thickness, suggesting that the improvements were driven predominantly by neural or functional adaptations rather than structural changes. Now, I'm going to point out that I'd expect to see. Now, when we listen to these results, there's a greater effect on the BFR side, but I'd actually think we'd expect to see less of improvement on the control side or the non-injured side. Because we've got to remember that the starting point for the ACL injured side is a lot lower. So there's a greater room for improvement. And also knowing that due to the low intensity of the walking program, that by not wearing BFR cuffs, there just isn't enough intensity to create big changes. And now knowing these results, if we could combine this with some form of resistance type training to get the muscle hypertrophy back, that would be really intriguing to see if we could get not only function, but also muscle size back to parity between the ACL side and the non-injured side. Because the protocol places minimal mechanical stress on the knee joint, it represents an ideal option for individuals who struggle with high load training or who require a joint-friendly method to rebuild strength months or even years after reconstruction. And the great thing about this type of program, because it is low intensity, is that you can put a BFR cuff on, go outside and enjoy the outdoors during a walk and get the benefits as well. Which then brings me to the point that I think it'd be really great to see a fully integrated rehab program utilizing BFR with strength and conditioning elements. I'd probably think that people in isolated cases may already be doing this. However, on a larger scale, that it could be published, like these other studies that I review, this may rather be difficult to pull off. In my opinion, BFR should be incorporated during walking, cycling, and any associated strength and functional training. And when you look at the evidence, the addition of BFR truly adds that element to assist with recovery from ACL surgery. Whether it be strength, muscle size, or improving pain or function, they all add up. And that's where we'll leave today's podcast. There's so many more studies that are in this area, but hopefully this gives you an idea of the power that BFR can bring to the recovery process around ACL reconstruction rehabilitation programs. In our next episode, we'll move on to a new topic in the rehab space. If you have any questions related to this, you can get in touch with me through my website, which is www.thebfr.co, or my socials @thebfr. You can also purchase your own BFR cuffs from our website, and you can find it at thebfr.co. And lastly, before I go, a couple of favors from me to you. If you know of someone who would benefit from this episode, please share it. And if you are enjoying the podcast, please give it a ratings on iTunes. Thanks for listening, and remember to keep the pump.